Good afternoon, everybody. So it's really welcome to AP Valves in Structural Heart 2022. I'm very happy to have you all, and really honored to have our old friend about the group here, Dr. Lan Young is here, and many of our friends, James Fleury, Dr. Lim Chan, and Dr. Ko Young-guk, and Oh Hyun-uk, and Dr. Zhang will join us remote Zoom. Anyways, as a live transmission about the TAVRs from the Assam Medical Center, so we're gonna start first cases. So, can you hear me, Dr. Bach?
Okay, I can
Okay.
hear you well. Can you hear us?
All right. So we have many, old friends here. Since you want to some say hello and start your case, though.
Okay, I think it's been a very long time to see you, everyone, and every our friend in person. Our EpiValve meeting. I'm very happy to show our live case demonstration in real time, live case transmission. Also, a little bit anxious. This has been a long time. Already past the 3 years. So before starting our live case demonstration, I'll introduce our team. My name is D.W. Park from Assam Medical Center. First assistant and the international fellow, Dr. Gosadi from Saudi Arabia. And the second assistant is Aram Kim, our senior fellow. Okay, Gosadi, can you introduce patient the background?
Okay, thank you. I'm Dr. Gosadi. Our patient today, she is 83-year-old female with history of diabetes and hypertension. She was admitted with a history of shortness of breath, New York classification 2 to 3. She had history of coronary intervention, PCI to proximal RCA in 2014, and she has also coronary angioplasty, balloon angioplasty to CIRC and OM 2017 at other hospital. The echocardiography showed severe aortic stenosis with normal LV systolic function. She had also past history of treated gastric cancer with operation 5 years ago. Next. As I said, she had history of diabetes, hypertension. Her body mass index is 26, and score is 7.2. Euro score is 4.3, so intermediate risk. Next. Echo showed LV function is 63. Aortic valve area is 0.6, which is very severe. Peak to mean gradient is 58, 35, less than 40. Trans aortic valve velocity max index 3.8 meter per second, and annulus is 20 millimeter. Stroke volume 30 ml. Stroke volume index is 19.3. She has severe annulus leaflet calcification of mitral valve, and mitral valve area 1.6 with gradient 10/5 with mild degenerative mitral stenosis. ACG showed normal sinus rhythm, and she has also good iliofemoral axis. Next. I think this slide showed this patient. As you see, she looks like a low gradient, low flow, but ejection fraction is more than 50. So in this case, we are going to check the stroke volume index, and in this patient is 19, is less than 35, which is going with paradoxical low flow, low gradient case. Next. Also, she has RCA stenosis angiography. We did IFR, which is 0.89, and also next FFR, which is 8.1. 0.81, which is in this patient is negative. So next. CT, as you see, showed at the annulus level, short diameter 18.4 and long diameter 23.2. Annulus area is 325, which is small. And next, please. At the level of sinus of Valsalva, the sinus to annulus ratio is 2.4, which is good and enough, large enough. And also at the level of STG, the ratio is 1.5, also is good. Next. At the level of LVOT, there is no calcification, and also the ratio is 1 almost. So next. Calcification distribution, as you see here, the total is 262, and which is like mild to moderate calcification. Okay, next. This is the calcium distribution on the aortic, abdominal aorta, and also distribution of the calcium on the aortic root. Next. Coronary height is enough. Left coronary artery is 12 and RCA is 14. Next. This is also showed the iliofemoral axis, which is good. There is some calcification infrarenal or abdominal aorta, but the area is enough. Next. This is the charting of the sizing chart of the CBM valve. As you see here is 20, if we choose the 20 millimeter valve, which we can get 100% oversized. And if we add 1 cc, we'll get almost 10% oversized. Next. Annular, this is the coronal view. Next. So we decided to choose Sabian 3 Ultra, Sabian Ultra 20 with 1 cc overfill, and we will go right femoral approach. Yes, that's it.
Okay, thank you. So if I'm gonna briefly summarize, this is a 83 female with a STS score was intermediate 7. So, and by definition, as everybody saw, this is a paradoxical low flow, low gradient. The mean pressure gradient 35, Vmax was 3.5. Ejection fraction was normal, 67. But so, and this is by definition, stroke volume index is 19. That is absolutely paradoxical low flow, low gradient severe AS. She has a very long-standing hypertension as well as diabetics. So I think that there is some arguable point. How can you define, how can you diagnosis of a low paradoxical low flow, low gradient? And the second part is how can you treat where is a paradoxical low flow, low gradient? So, and at this moment, I would like hear some comment, panel or moderator or question.
Any comment, Alan?
Hi, John Wilkes, Alan Young. Nice to see you in real person, I guess. So it's really nice to be back in Seoul. So we use the ratio of V1, V2 as well to measure the, if it's less than 0.25, then we would sort of classify that as one criteria for low flow, low gradient. If that's the case, I typically want to make sure I can get the gradient to be as low as possible as well. So this is the confounding question, 20 millimeter S3, what would your prediction of a gradient afterwards? And would you consider something a supraannular valve, for example? So that would be sort of good discussion to hear others. What do they think?
Absolutely, yes. So I think as you, the Alan's comment, this is also the very common things in Asian country, and this patient, if you're gonna put the SAPIEN 3, and we should select 20 on the basis of our CT algorithm. If you select another variable evolute, we can choose 23 and 26, and is So, and that is also very discussion point in the many Asian population require the smaller annulus, had the smaller annulus also requiring the small valve size. That is also the very debatable portion.
Well,
Any questions? So, and for this patient, the further diagnosis, the paradoxical low flow, low gradient AES, what we did for the diagnosis, Aram, can you comment on that?
We can diagnose low flow, low gradient AS with transesophageal echocardiography or double time stress echocardiography or CT scan. This patient underwent transesophageal echocardiography, which showed severe aortic valve calcification with opening limitation, and also planimetry showed aortic valve area just only 0.7, and also CT scan showed calcified aortic valve with opening limitation, and also aortic valve area was 0.7. So this patient can be diagnosed to true aortic valve, severe aortic valve stenosis.
Yes, absolutely. So Adam is commented in the current guidelines and for further diagnosis paradoxical, the low flow, low gradient AS recommended double time echo or transesophageal or CT scanning. We performed the TE, and there is a limitation, it's 0.7. CT scan shows, so we found a very severe calcification and the motion limitation 0.7, and absolutely there is also very the true stenotic component. So, and on basis on the guideline recommendation, symptomatic, paradoxical, low flow, low gradient, absolutely, and the AVR is a class 1 indication, and the level of evidence is BNR. So, and how can you treat in this patient in your cath lab, and any comment and any discussion for this patient?
Dr. Park, I'm Young-Kook Ko. So this patient has very small size annulus, and the Sapien 3 valve size is 21 millimeter for this patient. So is this patient physically active? Do you have any concern about the patient prosthesis mismatch after the TAVR procedure? So what's your opinion about that?
Yes, I think that is a very important question. And this patient, 83, and the physical activity is not, much active, and is a relatively old age. So I think the PPM concern could be the critical point to decide the valve type is also very debatable portion. If you consider PPM, it really matter. We should always consider the valve, the self-expandable valve rather than the balloon expandable valve. So, and there are very conflicting data. Even the last year we published the TAVR registry, and Alan and James is collaborated work in the published JAG intervention, and the PPM rate is much higher in Western rather than in the Asian population. However, impact, even though overall duration is just 1 year, the impact on mortality and hard clinical outcome just conflicting. In our TAVR registry, just a mild impact. However, another STS score, there is a higher mortality. There are still some prognostic impact of a PPM that's still controversial.
Hey, Doc Wo, it's James. Good to see you in person. I think you demonstrated that there's moderate to severe right coronary artery disease. There's a stent in the proximal right. So that's, I know the patient is older, but that's a consideration, re-access, and that would certainly be harder with the self-expanding valve in this case. So that's one thing to think about on the other side.
Absolutely, absolutely. So, some such like a patient is a prior coronary artery disease, also small annulus. We should consider several things, and coronary re-access, also problem with the PPM or next re-intervention. Then we should consider, and in heart team discussion, consider several anatomical or clinical factors.
You'll definitely get a smaller gradient with the self-expanding. The clinical significance of that, I don't think has been truly shown yet, though, long term.
Yeah, absolutely. So I think if you're going to put the Avalo system and the coronary re-access is much difficult rather than the Sapien valve. Okay, we're going to start.
Don't just remind me
So,
what is her height? What is her height and her weight?
Yeah,
I forgot.
yes, the 키가 어떻게 되죠? Height?
12
shows
and
height
14
body weight.
something. It's quite enough.
151. Yeah, 151 and 61 kilogram BMI is 26.
Pretty,
So and we are the predefined, and this is a 14 Edward sheath, and this is Amplach 1. So and the routine procedure and more than 95 cases, we do monitored anesthetic care. Our anesthetic care part, professor is always standby over there, and during discuss the vital status and something during the procedure. Okay, this is AL1. So, and the right femoral artery 14, the French issues, the left femoral artery pigtail caster was inserted. Also, and the temporary pacemaker was inserted. This is AL1. And usually, I first tried the soft Teflon wire. It failed. We select a further step, the ring torque wire. So, and sometimes the patient does not match the angle to pass the wire. At the time, I moved to the AL2. Sometimes we require the JR catheter.
Well, much better, no?
Okay, this is AL1.
Good.
Okay, good. It's too much simple. That's it. Okay. So the art push, this is AL1, and then I measure the pressure gradient, how some different in the measured by echocardiography, as also in this real time the hemodynamics.
Eberhard, personally, do you have any experience in terms of inability to pass the wires and cross the wire?
First of all, it's good to see you again doing it. I don't believe that you're nervous, but you look pretty cool and pretty calm. There's one thing, though, I would like to mention here. At 21 Sapien, you have to have a good reason for doing it, not because you're doing it all the time, but with an 80, with an octogenarian, probably ppm, probably doesn't matter if you're looking at in the future. This would be a completely different discussion when this patient was younger, because then it would make a big difference. And 21 essentially, at least in Europe, is banned. So this happens live,
Just as you compliment him.
But he's pretty cool. Now, granted, he's a little bit nervous.
There are situations, right?
Dr. Park, SJ will watch you very carefully here.
So, Eberhard, you suggest the self-expanding evolute out for this case?
No, but I think, you have to have a reason to implant a 21 because the gradient is high afterwards. In many instances, if you don't place the evolute or any self-expanding valve correctly, you're losing the advantage of supraannular anyway. So it is, at the end of the day, it's what you prefer, what you are used to. But with a 21 Edwards, it's something that is very, very rarely used in Europe.
Right.
So what wire are you using?
This is a Teflon wire, and then we are exchange it to the
Safari.
Safari wire. Okay.
I agree. We rarely use a 20 in the younger patient.
Oh, in the younger patients, the discussion is
This
different.
patient's 83, so I think it's dealer's choice.
Yeah.
I mean,
자, 좀 풀고.
her height, in inches is 4'11". So even though her weight is a little high, but I think, probably in the range of things that, sometimes if the area goes a little higher, we can go get a 23 and minus a few cc.
Yeah.
It seems like the valves are quite calcified, so you have to balance between getting a perfect result versus some disastrous result,
Yeah.
annular rupture and so forth. So I think, a 20 and if you need to, you might have to, post
Calcium
dilate
score is low in this patient,
Yes.
right?
So as you mentioned, Eberhard, absolutely this patient, the relatively young patient, we should consider a much bigger size the Evolut system is considering the long-term impact of the PPM.
You, Dr. Dogubak, you have some data, but in terms of PPM issues in TAVR areas and SAVR areas, actually, for particularly these patients, as I know, the body mass index not too big, and so we have, in practical point of view, we have not a choice for the choose the 2021. So issue is just Alan suggests, 23. We want to choose the 23 and two sessions on the field. And in particular, for case of low calcium cases, I prefer that one, or less. Right.
Eventually, the SMART trial will give us an
Right.
answer. When
Right.
this trial is done, then we have an idea on how the PPM issues,
Sure.
the self-expanding versus balloon expandable turn out.
Pressure.
Show us the gradient to work.
보여주세요.
You want to show us the
we're gonna show us
hemodynamics?
the simultaneous measure the gradient.
Yeah.
Okay, good. So can you see the hemodynamics up there? Okay, absolutely. There is some pressure gradient, and
More than I thought.
looks like a severe. Yes, over here.
Yeah.
So, and the LU EDP is slightly elevated, and there is a pressure gradient. So, at this moment, we are gonna put the Sapien 320 Ultra 1 cc overpill, and then measure the how pressure gradient, post aortic valve gradient was remnant, and how the hemodynamics is changed. Okay, and then the we change over there, then Sapari wire the small. This is ultra small. Okay, extra small. So so also there are some arguable data in the partner 1 or partner 2 study shows this like a paradoxical low flow, low gradient patient is there is some, even though observational study, TAVR was better than SAVR based on partner 1 study and partner 2 study. And so, could you, the panel and the discussion, then could you comment on that, and the paradoxical low flow, low gradient could be some important factor to decide SAVR or TAVR?
Well, we know we get, in general, larger effective orifice areas and less gradients with TAVR versus SAVR. So that's one reason why it may be at least physiologically favored to TAVR. And a lot of these patients are older and have comorbidities and may do worse with cardiac surgery than a less invasive procedure.
So, Dogu, you want to choose 20, 20
Yes, 20
S3
1cc.
Ultra,
Yeah, could you
1
yeah,
cc
23
overfill, right?
Ultra and right. So I think as I mentioned, S3 we can choose 23 and the bigger size and the 1 cc or 2 cc underfill, or the smaller size and 1 cc, 2 cc. The more pill, there is sometimes a very arguable, debatable part, and this patient is older patient also. Live case, safe is best.
Alan,
The reason why I select
we just started Sapien 3 Ultra, right? What do you
yes.
what do you think? Do you feel
Yes,
better?
I think everything is the same, but I feel some during the push slightly resistant. In the Sapien 3 is outer skirt and much elongated, and so there is some still some. How can you explain? Still difficult to push in the
Really?
23 or 26. Yes,
A
little bit.
At 20 is pretty easy, but once you get to 29, because
Yeah,
of
20
the
is pretty easy.
extra skirt, even though it's not really, the length is a little longer, right? So there can be a little bit more resistance. But I think in terms of, in general, the Ultra seals a bit better, so you have less perivalvular leak. So we tend to also implant the Ultra a little higher, just to give you even better performance if possible. So again, if you could, position it high, that will also give you a better shot of getting a smaller gradient.
So you have one
Okay, this is
cc
passage.
overfill. So what? How
Yes,
much
right,
oversizing
direct
is it?
stenting.
How much oversizing is
Yes,
it?
this is 11% oversizing.
11%.
Okay, test it. Okay,
Good.
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 The sapien. Okay, everybody okay? Patient on. Contrast. Okay,
Inflation.
쭉. 1, 2, 3, 4, 5. Deflate. Okay, patient off. Okay.
Well, he doesn't look nervous, no?
That's a fast deployment.
A little bit low.
Yeah.
All right.
We feel with
Can
you.
you measure Aram? Can you measure the echo?
Okay.
So we usually at the attending the fellow is immediately check the transesophageal echo, and in another live case demonstration, the intracardiac echo could be also is valuable to evaluate the significance of a paravalvular leakage, something like that. So in our routine, it's just to check it up the transesophageal echo. There is some significant immediate complication and like pericardial effusion, something like that. Also 피부에. 이 에코도 절로 전송이 되나? Could you check it up?
Yes, we can see that, right?
So, Dongwook, before you measure the pressures, what do you think will be the mean gradient across this 20 millimeter valve?
Yes.
Prediction.
Yeah, I think the mean gradient is before, and I think that after insertion we should measure, but I guess there is no pressure gradient at all.
Well, the invasive gradients are typically very
Okay.
low.
We'll see what the number is.
It's the following day when they.
Yeah, but
The
the
echo
20
gradient.
is
Okay,
interesting.
looks like there is no pericardial effusion. Okay.
Better not
This
be.
is,
Would you show the valve itself,
Okay,
cross section?
Okay,
No?
we're gonna check it up. 한번 더 잡을까? 한번 보여줘.
We don't believe, but transthoracic
Yeah,
echo
yeah.
too much.
We only use the echo for just quick check of pericardial effusion and major leak. It doesn't really do anything.
Yeah, major leak. Yeah, absolutely. I'm a little bit nervous. Many audience see your echo.
Sorry about the poor
Yeah,
quality.
poor
Well, we've-
quality. At the briefing time, is the window much better? Okay. 잘 안 보인다. Okay, 한번 찍어보자. Okay, we're gonna check it up the root angle and then measure the pressure gradient. Okay, over here.
You don't believe too much.
됐지? 자, zoom하고. It's a little the tension. Okay, echo. Okay, angle. 자, 풀샷. Good. So I think we can measure the pressure gradient simultaneously. We
Yeah.
already do, and the 1 cc morphine, and remove the balloon, and then recheck the hemodynamics again. Okay. 3. And the Sapien 3, the Ultra is recommended slightly more high in front. And how do you think the Allen and the Everard and the James? Is it you do the
Yeah.
recommended manufacturer recommendation?
Yeah, we try to aim for a little high, so maybe, again, sometimes depends on the angle. Where it's very horizontal, you may not be able to do too much, but we try to be, at least 90-10, so try to aim on the high side.
You really follow the lucent line as the guide, or follow the non-coronary cusp with the pigtail.
Yeah. Is it you follow the lucent line? Yeah. Sometimes the low passive overlap view is recommended the Evolut system, and the lucent line was recommended in the Sapien system, and sometimes it's finding the lucent lines sometimes difficult. We just do our previous classic method. Okay, we're gonna show us the hemodynamics again.
It's not bad.
So I think there is no
good.
There's no pressure gradient AR index. So we are slightly little back over here. Okay.
Very good.
First, there is no pressure gradient, even the 20.
Yeah, very
First
good.
AR index is more than 30 over here, and then I remove the every tester, and then check the final angel.
Dr. Park, on aortogram, the valve looks really small in relation to, sinus valsalva or, other structure. Are you sure that you measured correct the annular size?
Yeah. We
It's
are
too late
double
now.
check it up. Yes. Yeah. I'm confident the senior fellow Posadi, and he is measured more than 100, 200, 300. Yeah. Okay, test. And you ready? Okay, and you ready? Full Good.
Okay,
Excellent.
that's good.
RAO.
Perfect.
Yeah, so, okay, area view, and we can find how much related well. Okay, good.
I like it.
I think the final angel is very excellent. There is no PVL before. Could you before? So, we have discussed a lot of things, and this patient's typical paradoxical low flow, low gradient, and based on, we also checked up T and CT scan. Also, we discussed the small annulus. So how can you put which valve? How can you implant? There is also important debate for portion, and the final angiogram is excellent, and the overall procedure is very safe. Just take 30 minutes, and the result is good. So, any comment or question?
I'm Dr. O, and it's not uncommon. There's some discrepancy between catheterization-based and echo-based mean pressure gradient. So, could you show me the mean pressure gradient from echo?
Mean pressure gradient is 35.
After
35
TAVR procedure.
After
Can't tell.
TAVR procedure,
Yeah, in terms
and
of,
we're gonna show when you know. So usually our practice in the 1 day post TAVR, we measure the routine transthoracic echo, and then I will let you know is remain the mean pressure gradient. Yeah.
I
I
think
have a
it's
case-
overall, procedure is perfect, and however, final angiogram is clearly show that still, device size is a little bit, smaller than the sinus ratio, ST junction ratio, and so small amount of calcium. So I think, a little bit bigger device with less, the two-stitch on the field is, would be another choice for that.
Yeah, I think the sizing for S3 is still kind of in between sizes. It's always a little tricky still. A lot of just sort of like this, right? Is it a 23 minus a few cc, 20 plus a few cc's? It's still very much an art. And I think it's something that, between a 20 and 23 is really, 3 millimeters is 1.5 on each side. That's tiny. So it's really quite difficult to sometimes figure out which is the right way. So hopefully as we kind of move along, I think we can have better idea, especially in patients with low flow, low gradient. Do they really need to have a slightly bigger valve? I think that's still these gray zones that we could learn more as time goes on.
Okay, Doug, thank you for nice presentation.
Excellent.
Yes, we're gonna
Okay,
move
thank you.
a second cases. Dr. On,
First case
can you hear me?
깔끔하게 됐다. 깔끔하게. 알렌 형생은 많이 도와주시네. 네. 이첫 케이스 너무 깔끔하다.
Oh,
All right, Dr. On, can you hear me?
Hello, Dr. Ba, can you hear me?
All right, we can clearly, all right, hear you. And so we have, many our old friend and distinguished discussion here. So would you introduce your cases? And
Okay, I'm Dr. An from Asa Medical Center. This is my colleague, my real friend, Dr. Tang, and Dr. Che, my fellow. So we prepared the second case, hypertrophic valve disease case. Dr. Che, could you introduce?
Yes, thank you. This patient is 70-year-old female with diabetes and hypertension, and she was admitted for dyspnea on insertion. She had a history of Parkinson's disease, and the echocardiography showed severe bicuspid aortic stenosis with normal LV systolic function. Next. The risk factor of this patient is diabetes and hypertension. The STS score was 4.2%, which is intermediate OP risk. But her general condition very poor because of the Parkinson's disease, so we decided to plan TAVI. Next. Echocardiography findings, the LV ejection fraction was preserved with 66%, and cardiac valve area was 0.54, and mean pressure gradient was 77 millimeter of mercury. And transaortic valve Vmax was 5.5 meter per sec, and annular size was 20 millimeter. Next. This is CT findings of RT annulus view. The annular short diameter was 19.6 millimeter, and long diameter was 25.6 millimeter, and annulus area was 408. The annulus perimeter was 73.7 millimeter. Next. These are sinus of Valsalva and ST junction. Sinus to annulus area ratio was 1.76, and ST junction to annulus area ratio was 1.28. Next. There is no calcified lesion in LVOT, and LVOT to annulus ratio was 1.12. Next. We analyzed the total amount of calcium. The patient's total calcium volume was 324. Next, and the ICC and LCC was fused. Next. This is a longitudinal analysis of calcification. Next. The size of ascending aorta is within normal limit. Next. The coronary height was high enough. Next. Peripheral artery was large enough to transfemoral approach. Next. This is a sizing cable for Sapiens 3. We decided to Sapiens 3 23 millimeter with a nominal pressure. This is for 100% size. Next. Next. This is our TAVI planning for this patient. Thank you.
Thank you, Dr. Che. Do you have any comment on patient history and CT database?
Is it bicuspid aortic valve? Bicuspid?
Yeah.
All right.
Yeah. First of all, I'd like to say the welcome. I'm very happy to see you or our good friends in person. So welcome to South Korea, welcome Seoul, and welcome Asan Medical Center. So I'd like to ask you, the Dr. Grube and other friends, what is the incidence of bicuspid aortic valve in your TAVR population nowadays?
Well, I think there's a big geographic difference in occurrence of bicuspid. In Asia, in China, it's much higher than in Europe. The patient is 72. So, I mean, obviously we have it, but we don't have it that much as compared here to Asia. Korea, I mean, you have a lot of experience with bicuspids. China has more, and Japan. What is surprising, though, is that the amount of calcium is relatively low compared to the average bicuspid calcification patterns. So it's going to be type 1, I guess, if I'm correct, and it's going to be a straightforward bicuspid. The question is now, which valve are you using? I see you're using S3. I expected that because we are here in Asan, you're using mostly S3s. In this situation, to be honest, I would probably not use an S3 in this case. But because you can really take advantage in bicuspid aortic stenosis, you can place the valve higher. That is not to say that you have to go to 0, but you can place it high and take advantage in a 72-year-old of a lower gradient. And let us not forget, in bicuspid aortic stenosis, the annulus is only relatively important. It's not the main important, but I guess I understand that this is still a topic of discussion. But you can place the valve higher, and the sealing part or the anchoring part is not the annulus, it's the leaflets. So, and the raphe for that matter. I think with the 23, I think I'm going to be okay. If you take a sapien, I would agree with that. So we're looking forward to your procedure.
I'd say in Western populations, probably 5% bicuspid for TAVR.
Yeah.
So, Jianming, nice to see you again. So, I think the incidence could be depends on who is defining it, because as you know, our surgeons like to call every valve bicuspid because they think it should be have surgery. So if you have a tiny fusion, tiny fusion of a raphe that may be a millimeter or two, one of our surgeons will keep calling it bicuspid. So I think it really depends on how strict and how deep you want to call a type 1 bicuspid. Here, the raphe, I think, is pretty fused almost all the way up to the other leaflets. So that's typically a type 1, obviously. And it's not calcified, so it's pretty reasonable for a TAVR procedure.
Yeah, and I think, Alan, we have to now, with the latest publication from Paul Saraja, if you deploy a TAVR valve in tricuspid and bicuspid, you have to make sure that at least you should try a symmetrical expansion versus asymmetrical, because of the increase of halt or thrombosis in less than symmetrical expansion. So here we don't expect that because calcification is low. But I think if the calcium is higher, this will be an issue in the future.
Any comment on that?
Thank you very much. Very nice comment.
Jianming,
Yeah,
do you
so,
always pre-dilate? Do you pre-dilate all the bicuspid fuse or not?
Yes, usually the bicuspid valve we prefer the pre-dilatation, but in particular this case, the calcification is the lower than usual bicuspid valve disease. The 300 aortic valve calcification is similar to less than our average of tricuspid aortic valve disease. Average of our tricuspid aortic valve disease aortic calcification is around 400. So the low calcification volume in aortic valve, I don't like the pre-dilatation. I like to the direct device implantation.
Okay, I think this particular case is very layered, bicuspid, not the typical one. Actually, it's very normal size of aortic root, and calcium amount concern is a little bit, larger than the tricuspid valve. However, this case is a small amount of calcium, quite soft, tissue, and so I think it's a good candidate for TAVR. Still, we have, controversial issues, sabers and TAVR for bicuspid. However, for particular these cases, I think it's a TAVR would be good, choice. All right. Dr. Anna, why did you do that, right?
Parkinson's.
Yes, particularly this patient, the ascending aortic diameter is within normal range, so it would be better for the TAVR than the SAVR. If ascending aorta is larger, then we prefer the SAVR. So could you show us the previous one? While we are waiting, I already inserted the wire to the aortic valve. Next, sometimes the aortic valve wire insertion is not easy in the case of bicuspid aortic valve, but in this case, not that difficult.
Also, strip wire.
Yeah, this is the ring torque wire, steel wire, and flat guiding catheter.
So, Jianming, if you wire the bicuspid, is this any different from tricuspid, or you just try and error like this?
Just try and
Yeah.
actually no difference between the bicuspid and tricuspid
Any
in sense
different?
of
Ever?
No.
technique.
Well, you have to be careful.
I usually have to say I go down and then look at the jet where the wire is tipping to, and then I try to.
All right.
When it's severely calcified, you could pierce a leaflet. You
Yeah.
have to be careful about that.
Yeah.
But some operator use the soft wire, but I prepared a little bit hard wire to insert the particularly very calcified aortic valve. But should you be careful? So I think there is no difference between the tricuspid and bicuspid aortic valve disease. I insert the pigtail, and can you see the pressure gradient between the LV and aorta?
Very high.
And I like to insert the safari wire. All procedure is similar to the tricuspid aortic valve procedure, which we're saying.
So at Asan, everything
I
is
like to select-
standardized. And which wire are you using?
Just all right. Standard Safari force.
Yeah.
And the right.
Yeah, safari is just more safari wire. So I like to select the 23 sapien valve. Usually our target device oversize is 10% in tricuspid aortic valve, but the bicuspid aortic valve, our target is just a nominal size. 23,
So-
area oversize is 100%. So I like to start with the nominal size of Sapien Ultra 23 device.
Yeah, so you're oversizing in relation to the annulus, correct?
Analyst is
Your nominal to bicuspid, that generally is a more calcified bicuspid, right? So here you may need a bit more or not. Volume wise.
actually we in hard cores, hard calciums, large calcium scores. We use the less than 5%.
-5?
Yes. However, particular this case is a small amount of calcium, and so we're gonna choose the 23 nominal first.
Yeah. Okay, fine tuning. And then go for okay. Could you change to the implantation view? Without pre-dilatation, low calcified, even though bicuspid aortic valve,
Good.
device passing is very smooth. Test please.
Yeah.
So I like to start the implantation. Ready? Facing on. Contrast. Okay.
Really
implantation.
high. All right, it's good.
1,
Perfect.
2, 3, 4, 5. Deflation. Facing off. Okay.
I think you see a
show
slight
the outer
slight
wall
indentation in the non-coronary cusp side, so that's where the calcium was heaviest, wasn't
Yeah.
it? And here.
Blood pressure is stable.
Blood
100.
pressure
80. Just stable.
80,
Sign-
80,
sign-
20,
signs
something
over
like
here?
that. All right, a little bit high
Yeah.
positioning. I think it's good. Perfect.
So there is some indentation in the device. So the first I like to see the
Ooh.
echo first. No
Good
pericardial
echo.
infusion. Okay, could you show us PVL?
What do you think about it? The procedure time itself is just 2 minutes, right?
Yeah.
All right. So
Actually, we have a preoccupation. The bicuspid aortic valve should be difficult by TAVR, but depend on the calcification volume. So why bicuspid aortic valve is difficult to be treated by the TAVR? I think that is due to most important thing is the calcification. If there is some low calcified bicuspid aortic valve disease, I think it should be a good candidate for TAVR like this.
And I wouldn't want to post-dilate this because that nodule is pushed right up against the sinus on the non. You can see it, as Alan pointed out very nicely on this shot. It gets pushed right into the non.
The sinus as well.
Sinus,
so
yeah.
the lower
Yeah.
bottom of it.
Yeah, so I would be very loath to post-dilate this valve. That's when you run into trouble.
What diastolic blood pressure is 70 or 62, 70, so similar to the baseline diastolic pressure. So I'm convinced that there is no significant paravalvular leakage.
Oh, yeah, there would be no leak. It's just a matter of, is it fully expanded on that side? It probably isn't. It's probably a little indented. Well, you just have to live with that.
So the one more thing is I can do one more the high pressure post balloon dilatation to make a better shape. So should we do one more or just leave it alone?
would you show us echo findings and so?
I'd leave it alone because that calcium pushed all the way to the edge there already.
Function is false. We don't want to fix shape itself.
Let's just check the gradient if you don't mind. Just see what the
Alright.
gradient is. The
PBL. What about that one?
only if the gradient is really unacceptable, then
Yeah.
then we have to.
Leak is rarely an issue with either
Yeah.
any
think it's
type
good
of
enough.
valve anymore. The skirts are so good now that it's really unusual to have more than mild leak.
So the echo view is not good, but anyway, there is no
All right.
leakage based on the echo view. So
Electrogram first.
I like to make, yes, just a moment. So, ready? Ready?
Yeah, your wire is in place, so it's kind of hard to tell. So I would check with the
Right,
pigtail.
so before
Yeah.
remove the balloon system itself, and so we're gonna check first like this, and maybe we need a little bit further. All right. Anyway,
The Safari is pretty stiff, so it may tend up your valve a little bit. So you want to check your pigtail.
just 0% area of expansions. However, the calcium score is lower, and so maybe we need a little bit more, 5% and something like that. Okay, I know.
The Ultra also warms up after 5 or 10 minutes, so if you're patient, an initial leak may look a little
Great.
better.
Very nice.
So based on the LV and outer pressure, there is no pressure gradient between LV and RV, and AR index looks fine. So
Yeah, I don't think
I
you need
like
to
to-
post dilate. Yeah, I don't think you need to post dilate at all.
Yeah.
So even the shape's
the
slightly there.
is not necessary. Yeah. So I like to remove the
LV pigtail.
pigtail, and then I like to check the final autogram, and then I like to finish my procedure. Ready?
A little leak on that side.
Yeah, but that's, I mean, that's where the calcium is.
It's right where the
There
nodule
is
is.
some leak.
Yeah.
Yeah. Ready?
Not much, right? I like area view better than the area view, right?
There must
but it
be a
is
small leakage through the calcified nodule, but as Alan mentioned that there is a calcified nodule, they have some risk of the aortic root injury. So based on the pressure gradient and pressure tracing and aortogram, I'm very satisfied with this not perfect but acceptable result.
Great. I think it's perfect. Any comment on that one, James?
No, yeah, I
Other
think,
thing in terms of bicuspid
I
is
think
it,
it's important not to push too hard in these bicuspids. You're probably at a higher risk of annular injury if you're too aggressive with sizing and post-dilation.
Dr. Alonso, do you have in Europe any policies for the bicuspid AS?
Yeah, I think mainly calcium and the distribution of calcium. Some of them are too much and you really are too risky for doing a TAVR, especially if the raphe is calcified, then you can basically form a harpoon and push out the sinus. So you have to accept this is actually very good. I mean, the gradient is very, very low, and then you have trace paravalvular leak that would probably seal the way. The thing that I struggle with sometimes is still whether these fused raphe, is it better to do a little pre-dilatation to release some of that tension, even though it's not like to passing the valve. Passing the valve you can pass, is whether you can open up the raphe so when the valve goes in, it expands a little bit more symmetrically rather than get pushed to one side or the other. So that's the only thing that I might now tends to do a bit more, is to pre-dilate with this 18 millimeter so that facilitate the valve expansion to be more even.
Any comment about bicuspid?
So a question to my panel members here. Do you think that we will have a randomized trial on bicuspid type 1?
Against surgery?
You mean self-expanding versus balloon expanding?
No. Well, no. I mean against surgery.
No.
Nobody will fund it, right?
Yeah, I don't know what the mechanism, it would have to be a
You think we'll have it? No.
government-funded trial.
Bicuspid randomized study?
Yeah.
Is it personal things? I don't need that. If TAVR is choice, however, is it too tough? Send the patient to a surgery, right? As that depending on CT evaluation and pre.
It would just be hard to show a mortality advantage of either therapy. So I think the signals aren't there that there's a big difference.
I think it's hard to find patients that are equipoised for getting both, meaning there's clearly patients that are super calcified or their root is a little big. Then why would you do TAVR, right? Especially young. So almost like when you sort of do a trial like that, you end up with a very small population that who cares almost. That
And then
what
it's
you
not
do.
real-world
Right,
patients
right.
anymore, so it doesn't help you practice.
So then the result would be surgery better than TAVR in bicuspid valve, which
Turns
has
into vanilla.
meaning.
So I don't think it'll happen.
Yeah.
Okay, Dr. An, this is really thank you for your
Good job. Thank you.
yeah,
Thank you.
Young
nice
men.
presentation.
We should always have a drink the evening before. You performed really well.
Yeah. So, yeah. Dr. Park is going to make some opening remark for our 11th AP Valve and Structural Heart 2022.
Thank you, Alan. And really, I want to say hello to you all. Good morning, good afternoon, everyone. Welcome to AP Valves and Structural Heart 2022. It's so great to see you again in person after 2 years of a virtual meeting. So I'd like to thank all of you present here, despite difficult situations with the COVID-19. And especially thanks for our faculty members for joining this program to show your in-depth knowledge and expertise. This year, 2022, is a very special year for us because it's been 20 years since the first in human TAVR procedures was performed. I would like to take this time to express my admiration to the Dr. Alan Cribier, for his noble attempt to achievement, which have contributed to the interventional cardiology to a great extent. In line with the meaningful 20th anniversary, the AP valves and structural heart will deal with the TAVR from the first concept up to the most recent development in clinical trials. For 2 days, there will be 14 live case demonstrations from the 7 different international cardiac centers, which are based in China, Germany, Korea, Taiwan, and the United States too. And thought-provoking lectures by our expert faculties will also be provided. For passionate learners, we prepared interactive hands-on training centers and satellite symposia so that you can learn about the RADIS device and the practical tips and tricks. Enjoy our program, including the on-site activities, and I hope it will bring a lot of insight into your clinical practice. Thank you. Thank you.
So, SJ, will you introduce Alan? Oh, I do it? Okay. So I think we will have a recorded session on a very important topic, obviously, by one of the pioneers, if not the pioneer of TAVR, Alan Cribier. Alan is an incredibly important person for our field. He always moved things beyond the horizon. He had a great vision, and obviously we wouldn't be here talking about things, that gone in 20 minutes when he started 20 years ago. So it's really a great pleasure and a great honor to introduce Alan and listen to his lecture, the 20 years anniversary of TAVR, from bench to clinical practice. It's particularly important because it's not about numbers, it's about personal impressions and personal experience. So very much looking forward to his recording.
So I'm showing these slides. Today, it's a very special year. 2022. It's the 20th anniversary of TAVR. We did the first case on April 16th, 2002 in Rouen, France. And this is the place where I am talking to you today. So I have been asked to just summarize the very first experience with this procedure. This is my disclosure. On May 21st, 2002, we had a great celebration of the 20th anniversary of TAVR in Rouen. We had more than 600 people coming from all over the world, and this enthusiasm of the population, is clearly explained by the incredible expansion of this procedure over the last 20 years. So let me try to explain to you how everything started. Over the last 40 years, I have been clearly aimed at developing cardiac catheterization techniques for treating degenerative aortic stenosis. And the whole thing came in 2 seasons. The first season was in 1985 with the development of balloon aortic valvuloplasty, consisting in dilating the aortic valve with a plain balloon. And then in 2002, we did the first transcatheter aortic valve that we call in France TAVI, T-A-V-R-D-I, TAVI, and in the United States and the rest of the world, TAVR. So we have 2 landmark publication of these 2 technologies, first in the Lancet in 86 and Circulation in 2002. So there is a clear-cut rationale for these two technologies. A single goal to provide a life-saving therapeutic option for patients with symptomatic aortic stenosis and declined for surgical valve replacement. So there is a very strong clinical need here. Because that without surgical valve replacement, today, more or less, one-third of patients are not operated on and will die very, very quickly within 2 years, a mortality rate of 80%, which is not very much acceptable. But in the 80s, when I started being interested in this pathology, the situation was worse. Because surgery was also declined in all the patients older than 70 years of age. So we had probably more than 50% of the patients turned down for surgery. And so I really spent a lot of time to try to solve this major unmet clinical need. So the first thing that I proposed was to do first the aortic valvoplasty. We're trying to enlarge the aortic valve orifice with balloon dilatation, and you can see here the very first case in the world of a balloon aortic valvoplasty. I was dealing with a very symptomatic woman who had several syncopal attacks every day, and she was almost dying of the disease. And I very carefully, inflated first a 20 millimeter balloon and moving up to 23 millimeter. And we got this kind of a moderately good result. But by chance, these patients remains 2 years without any symptoms and returned to normal life. So immediately, we did in Rouen the very first series of patients with balloon aortic valvoplasty. All the patients have been declined by the surgeon for surgical valve replacement. And this first series of patients was published in Lancet in January of '86. And it was a kind of bomb effect in the medical community, with tens of thousands of VAV done worldwide, a number of index articles and huge registries in the United States. The FDA approved the technology in selected cases, but there was a major limitation, which was the early restenosis within 1 year, in 60 to 80% of cases. So this was not acceptable, and so the question was what to do next. So from 1990 was for me the birth of the idea of TAVR. As a solution against early restenosis post-balloon aortic valvoplasty. It was a crazy concept, and I stated in '90 that I wanted to implant a valve prosthesis within the diseased calcified valve on the beating heart using regular percutaneous catheter-based techniques and local anesthesia. So this was at first sight totally crazy. First of all, everyone said that it was impossible because of the heavily calcified valve. This is a valve we have to deal with in practice, and the surgeons know that very well. So there was almost no chance of crossing the diseased valve with a prosthesis and deploy it on site. Also, it was considered to be extraordinarily dangerous, especially on the beating hearts, because of the surrounding structures, the coronary ostial valve and the mitral valve and the His bundle just below. So no chance to succeed. But actually, I was very keen at developing the concept of balloon expandable valve because I noted that during a balloon aortic valvoplasty, we can always inflate the balloon totally with a circular balloon expansion and whatever the amount of calcium. So the question was, could a balloon expandable stent be used to maintain the valve open? So for that, we did in Rouen a landmark code of history, which is absolutely fundamental in the history of TAVR. We used the balloon expander valve in 17 fresh specimens of patients who died of calcific aortic stenosis. I did that with Hélène Etcheninoff, who is now very well known and who is heading the Department of Cardiology after me, and another colleague, René Koenig. And this is what we did. We implanted the stent. It was a Schatz stent, a Palmas stent, within the calcific tricuspid aortic valve that you can see here. We did that in 17 patients. And each time, we could observe the circular expansion of the valve. And this was redone, in very major severe cases by Renu Birman in the United States in 2002, just before we did the first case. And she was very, very surprised to observe that it was actually possible, even in this kind of diseased valve, to inflate the balloon expandable stent and maintain the valve fully open with a circular expansion of the stent. So this was a very positive impact, on the future of the procedure. Also, after the stent was implanted in some patients, we kept the aorta vertically, and this is a longitudinal view showing that the stent with a height of 17 millimeter could be very clearly implanted on the annulus. Without occluding the femoral artery, we had enough room here at the left main and the RCA, and without, impacting the intraventricular septum with a His bundle and the insertion of mitral valve. So we could respect the adjoining structures. And also, we did consider, like in this case, for example, that the forceps was needed to remove the stent with a traction force of 2 kilograms to remove the stent, meaning that the risk of stent embolization was extremely low. So these results were very much encouraging. And so I started, for a patent application, a European patent, did some drawing of what could stented valve look like, and you can see here a stent, the tricuspid valve inserted inside, in systole and in diastole, and the stent has to be covered a little, at the bottom to prevent aortic regurgitation on the side. And the valve structures could be biologic or polymer, and we needed a high radial force balloon expandable stent, and with this external curve. And this is a model of this valve that was done by our surgeon, Professor Bessou, here in Rouen. He made a handmade model of percutaneous valve using a very thin tissue. And this was not to be implanted in humans. This was just to control that it was possible to make it. And also, the important lesson was that when this valve was crimped over a balloon dilatation catheter, actually this is a critical attack balloon dilatation catheter that we use for balloon valvuloplasty, the crimped diameter of the valve is 8 millimeter. It means that it became conceivable, to use transfemoral approach retrograde, and this was the goal of the procedure, of course, to implant the valve straight away by the retrograde approach coming from the femoral artery. And so this was in my mind, the different steps of implanting a stented valve in calcific aortic stenosis. And then I started looking for a sponsor to make a progression of this concept, and unfortunately, it was a complete failure. Even though I knocked the door of Edwards Life Sciences and Medtronic, all the answers were always the same, totally unrealistic, major technical issues, impossible to stent a calcific aortic valve, a lot of potential lethal complications during the procedure that you can read here. Also, it would never be approved by the FDA, which was a very important argument for the American companies. And the surgeon said that the surgery was covering 100% of the need, which was not true, and that there was no indication for this procedure. It was the most stupid project ever heard, and the company were pushed to forget it very fast. So was it the end of the story? No, it was not the end of the story, because I met very important people on my way during this period, two engineers from Johnson & Johnson, Stanlow and Sam Rabinovich, and Martin Leon from the United States. And these three people, believe it or not, they thought that this technology had a future. And so with three of them, we created a startup that we named Percutaneous Valve Technology, with the goal of developing the valve ourselves. And by chance, we could find a company in Israel, a small company, biomedical company called Aran, and who invested and developed the device. And this is, the team of people, in Israel. These people are responsible of the development of TAVR, especially this guy here, Asad Bash, who was the main engineer, who was really a strong believer in the technology. And so he had to fit with this challenging request, making a prosthesis consisting in a highly resistant frame containing uni B or tricuspid leaflet valvular structure, able to be homogeneously compressed over a high pressure balloon for its introduction in a sheath of 7 to 9 millimeter in diameter, because the goal was to go from the femoral artery, enlarged by balloon inflation to an external diameter of 23 millimeter without damaging the frame and the valvular structure. So it was extremely challenging to make that, and they made it very fast. Within a couple of months, they came to me, and I went to Israel, to observe this prototype that they made, consisting in a 3D flat valve that you can see here, made first of polymer, and then they moved to equine pericardium, and finally bovine pericardium, stainless steel stent, a single diameter of 23 millimeter, according to my indications. And when this device was crimped over a balloon, it was a 24 French crimped size, which was a little too big, but well, that could fit with the majority of patients in real life. So with these valves, they made in Israel a number of in-lab valve tests concerning the hemodynamics, the durability of the valve, which was proven to be higher than 5 years. You can see here the valve working in the bench. They did some radial force experiment. They studied the stent geometry. And at the same time, with each of the prototypes that they made, we were doing with Hélène Ushaninoff again and a veterinarian, Nicolas Borenstein, in Paris at the SERA, in a very good clinical setting, operative room setting. We did the insertion of this valve, the crimped over a pneumatic balloon, through the carotid approach using a 14 French sheath. And we succeeded at the beginning, to implant the valve on the orthotopic position, just at the level of the native valve. You can see here the valve implanted. And we did also with Hélène 5 months experiment in the aorta. And you see here that after 5 months, the valve was working extremely well. And at 5 months, there was no calcifications, no problem on the leaflet on those examination. So this was absolutely great. And the question was, when should we move to human? Because we could, with this animal model, answer important lessons on the vascular access, the use of latches, which were very, very unusual at the time, the delivery system, the guidewires, all the procedural aspects of valve implantation. We studied also the anticoagulant regimen, but we had strong limitations. We have strong deficiencies in the animal model because there is no aortic valve calcification, there is no aortic valve degeneration, and there is a different arch anatomy. So we didn't know whether it would be possible or not to implant the valve in human, and so moving to human was the hardest decision to make. And we did it. And actually, we received on April 16, 2002 in Rouen, a 57-year-old man with in cardiogenic shock with almost no heart contractility and ejection fraction of 12%. He had multiple comorbidities and also an intraventricular thrombus, a floating thrombus. He had 2 occluded bifemoral grafts, so we could not think about implanting the valve transfemoral. He was turned down by 3 surgical teams in France, and the people from the north of France sent the patients to us in Rouen for doing an emergent transseptal balloon aortic valvuloplasty, but unfortunately it didn't work well, and the patient was back in shock in 24 hours. So, this was a real challenging decision to take, to try a transseptal aortic valve implantations as a life-saving procedure because the patient was only 57 years old and that he was very much demanding to be improved. But these patients had all current contraindications of failure, which is just unbelievable. So we did that. And, the technology consisted in going through the transfemoral vein, crossing the septum, which had been dilated with a 10 millimeter balloon, and following these arrows, turning around the floating thrombus, which was here, and reaching the aortic valve. So the guidewire was introduced in the femoral vein, and going all the way down to the femoral artery on the other side. We had enough room, in the femoral artery to get the guidewire across. And you can see here the very first case done in the lab. You can see here the time of valve positioning, and here the time of valve delivery, which was extremely moving, extremely stressing. And this is the valve implanted just inside the calcification. And with this result, on the decreasing gradient will almost zero, and the raise of the aortic pressure, absolutely fantastic. And at this time, I was able to stop all vasopressive drugs that he was receiving, particularly adrenaline. And this is a patient immediately after the procedure. It's the very first patient implanted. And this is the same patient 8 days later, totally transformed. It was kind of resuscitation. So the publication of this case in circulation was extremely important for the whole medical community. Unfortunately, I had to wait 1 year, to obtain the French approval for starting a prospective series on compassionate cases. And we did this series, 38 compassionate cases, with a life expectancy not more than 2 weeks. This was the definition of compassionate case. And we did 2 successive studies, I-REVIVE and I-RECAST trials, using the transeptal approach, because the French government told us that it was necessary for us to use the same technique that was used in the first patient. And so the lessons from this first-in-man case was that it was feasible, that there was an accurate valve placement, no valve embolizations, no coronary occlusion, no mitral regurgitation, no AV block. We had an optimal valvular function in all cases, excellent hemodynamics, and we had just one big limitations, in this series of patients, the paravalvular aortic regurgitation above grade 2 in 25 persons, because we had a single size of 23 millimeter valve to use, and we know today that it's absolutely too small. The results of these studies have been published in the JACC in 2004 and 2006. But I would like to show you, before finishing, the spectacular improvement of some patients, which was a key element for the acceptance and future expansion of TAVR. So don't forget that we are using the autosomal approach. This is a patient number 3, for example, an 83-year-old woman who had 2 aortic valvuloplasty procedures, who came to us in casual shock absolutely dying. And we had to use a transeptal TAVR as a last resort option. And the result 6 months later, this patient is totally resuscitated. She is among her relatives doing absolutely well. And the cherry of the cake on the cake, was that 1 year later, she was invited to Washington, D.C. from France, and she could travel to the United States. And you see the shape of this woman is absolutely remarkable. And these are the people from Edwards, and here Stan Rabinovich and Asaf Bash, an engineer who made the valve. And this patient was absolutely doing well. And 6.5 years later, she was here attending the workshop that we had on TAVR, and we did a live echocardiography at that time, showing that the valve was working absolutely well with hemodynamics unchanged since 2004. So the patients died a little later of breast cancer, but it was a great, great example. Also, I would like to stress on the patient's number 10, because in these patients, she had also a mitral stenosis, making it impossible to use the transeptal approach. And this patient was the very first one with a planned retrograde approach. And it was unbelievably simple. The procedural duration was only 16 minutes. We did that under local anesthesia. You can see here the valve implanted, working extremely well, like the valve that we are implanted today. And it gives us a first vision of a TAVR valve implanted retrogradely. And this is the same patient 5 years later doing exceptionally well. So these patients have played a very important role, in the dispatching of the technique in the world. So just briefly, in 2004, Edwards Life Sciences acquired percutaneous valve technology, and immediately they made some changes, from the Cribbie Edwards to the Edwards Sapien valve, adding a 26 millimeter size, which was extremely important. And the schist size was at the time 22 French and 24 French. And it was conceived for implantation via the retrograde transfemoral approach. And for that, they developed a delivery system which was extremely brilliant, the retroflex catheter, steerable. And John Webb in Vancouver, Canada, did all the important work on it. And very rapidly, in 2006, they added this nose cone, and which was a retroflex 3. And with this system, they did all the European registry, including the source registry in Europe, including thousands of patients that have been a great determinant to the success of the procedure. And also with this device, the very first landmark pivotal randomized partner US trial. And the consequences of this trial. Also, in 2005, the surgeons became interested in the technology because the transapical approach was also proposed as an alternative to the transfemoral approach for those patients who could not be implanted transfemorally. And, it was also a very bright technology. This is the first transapical case performed in 2005 in Leipzig, in Germany, with Michael Mack and Frederick Moore, and I was there and as a devil entering into the operative room, but the surgeons, were rapidly convinced about the possibility of doing it. So this is the follow-up, in 2004, Edward Strike Science acquired PVT. They did feasibility studies. We had the CMARC in 2007, post-commercialization registries from 2007, partner 1 on high-risk patients, partner 2 on intermediate risk patients, partner 3 in low-risk patients in 2019 with different model of valves, always improved with smaller size and more efficacy. I want to say a word about the core valve, the Medtronic core valve, that was launched in 2004, a concurrent device which highly contributed to the incredible expansion of the TAVR. And this one was conceived by Jacques Seguin and engineers in France, and very much supported by Edward Gruber, that you know very well, and Jean-Claude Laborde. And this valve had a similar successful scientific pathway with improvement in the device and improvement in the results. So in August 2019, it was the apotheosis of TAVI. FDA approved the TAVI for low-risk patients above the age of 65 with 2 different models of valve, the Sapien 3 that we developed and the Medtronic Evolut valve. And you know that in a single year, 2021, we had a high number of 182,000 patients implanted in the world in a single year. So a spectacular worldwide expansion. Today, we have 1.5 million patients treated with TAVR in the world in more than 80 countries. Could you believe that, when you saw the very first cases? And there is a predicted growth of time for within 10 years. So, my friends, developing TAVR was a long road, but the fight was worth it. This is where we are today. This is what I wanted to say concerning the very first step of the procedure. Thank you very much for the invitation. Thank you, Dr. Park. Remember the time we were doing the first TAVR in your lab together, side by side. It was a great moment. So have a great meeting. Thank you very much.
Great talk, great talk. So, once again, I'd like to express sincere admirations to Alan Cribier's achievement. All right. Next talk is Dr. Edward Gruber. He's my old friend. He's really one of global pioneers. And thank you for coming again. Okay, he will give us next innovation in transcatheter valve intervention, new valves, and new technique.
Yeah, thank you very much, SJ, and I really appreciate this important invitation to the 20th anniversary of this meeting. It is so good to be back. My nose has been scarred from all the tests that we went through, coming from India, but it's definitely worth it. And you know, we can see now the difference between Zoom meetings and personal meetings, the networking and the exchange of opinions is just so much valued, and it cannot be replaced by any different television technique. So I'm very grateful, SJ, that you invited me, and we go beyond what you've heard with Ellen. We talk about the next innovation in transcatheter heart valves, and then the new valves and new techniques. Here are my financial disclosures. As we move on, we know the ideal transcatheter heart valve, and if you imagine now Alan Crevier's words on how crude the very first device was, nevertheless, we created an avalanche of evidence during the last years. And I think it's important to note that we still are striving for an ideal heart valve. And, you know, the criteria are summarized here: optimal valve performance, minimal interference with surrounding structures, simple, predictable deployment, low complication rates, low profile for transfemoral delivery, and of course, the valve has been durable. As we move into the younger generation, not necessarily lower risk, but particularly younger patients, the priorities have changed from the very beginning to now and the future. Return to daily life, lifetime management, that's what we're calling it, and of course, the everlasting question of durability. If you recall at the very beginning, when the surgeons disagreed with our approach, primarily there were technical arguments, but then came the question, it will never last. And only time will tell, and now after 10 years, we have a glimpse into the future, different durabilities, and maybe some things just take some time before they become obvious. Priorities for the future: the design has to be focusing on lifetime management of this disease. We should optimize the index procedure, extend valve longevity, maintain coronary access, and plan for THV in THV. The heart valve conundrum is summarized on this slide if we look at the tissue valves and the mechanical valves. Each have their advantages and disadvantages. Obviously, if we look at the mechanical valves, the quality of life, anticoagulation, and no TAVR option are the major issues. And the tissue valve, obviously, durability. As we talk about these particular valves, I call it the durability controversy. Until there's long-term, that is to say more than 10 years, or at least 10 years, reliable clinical and echo data treated with modern-era transcatheter bioprosthetic valves, there will always be concerns regarding durability. But having said that, let us remind it, THVs have collected more rigorous durability data than any surgical valve until now. We should not forget that in this discussion. And here's the promise: one valve for life. That's what we really would like to have. As you can see on the left side, the mechanical valves, we started in 1960 with the mechanical valves, moved on to where we are now, the bioprosthetic valves, and now looking to the future and beyond, synthetic permanent polymer and possibly even living. So from non-living valves to maybe one day living valves. The current landscape is very well known. The current industry standard is SAPIEN 3 and Ultra Evolut R Pro Plus. Increasing clinical use and next in line Actuate Neo 2, Portico Navitor, MyVal. Rebooting and increasing momentum, definitely JenaValve, J-Valve, and the Venus A-Valve. And then, as you can see at the bottom, and those are not the last ones that go and went out of business. Also, it seems to be important to be reminded that we have self-expanding versus balloon expandable valves, quite obvious, what we see here, and then supraannular versus intraannular. We will see whether these differences play a role, particularly in the durability question, but this is what we have now, and we should be reminded. So the current standard for TAVR is Medtronic Evolut R and Pro Plus, and Edwards SAPIEN 3 Ultra. We all know this. Next in line for TAVR is Evolut FX. You can see here, the nose cone has been redesigned, more flexible capsule, single spine shaft, an optimized stability layer, and 3 radiopike inflow markers just located adjacent to the commissures, which is important for the commissure alignment. And then they're positioned at the 3 millimeter target depth, so we do have a target depth noted by these markers. Next in line, the Actuate Neo 2 from Boston Scientific. You know that is the inner and outer pericardial skirts in order to address perivalvular leak. It is a self-expandable valve, and we will see and hear more about it. And then the Abbott's Navitor valve, that is a valve that has an inner and outer cuff addressing the PVL issue, the large cells, as we all know, for coronary access, and this is definitely coming along. But now we're moving beyond those that are well known in the market, which we call rebooting or increasing momentum. The Jenner valve, and we will hear a little bit more about it in a second, but we'll also have a live case this afternoon, China's J valve and China's Venus A valve. The J valve has moved from transapical to transfemoral. We haven't heard much about it, but it is a transfemoral delivery. Those nitinol claspers here clip onto this, the leaflets and seal and position the valve, so very well suited for aortic regurgitation. This valve has been approved by the Chinese FDA in 2017. We will see and hear more about it, hopefully, in the future. This is an angiogram done by, on the courtesy of Dr. Hennessy from Vancouver, who have the most experience in the Western world with it. And you can see here very successful elimination of aortic regurgitation. Very interesting valve. And then here Venus A and Venus A+. It is a self-expanding valve, supraannular, and the Venus A+ is retrievable and repositionable, as we all know. Venus also has a pulmonary valve, which is the Venus P valve. And then here we have the Jenner valve. It is a very special valve, initially designed for aortic regurgitation because it has these little locators that you will see. Those clips align with the sinuses and set the implant depth and avoid low implants. So by definition and by design, you cannot implant this valve very deep. It is self-expanding and supraannular, ongoing trials in the US and in Europe. In Europe, it's finished, and in the US, it's ongoing or almost finished. So let me just briefly mention the specifics of the Jenner valve. You can see here, it does have locators. Here on the side, and you would see in the live case and on the case that I will show you in a second, it sets the valve to the commissures, to the native valve. So by design, you have a commissure alignment that other valves are striving for, at least self-expanding valves are striving for. This is by design a valve that aligns with the native commissures. It does have a definite implant depth, of course, because the clips are clipping the graspers are clipping the leaflets. It seals naturally, so it doesn't have any skirt around it. It does have also here very large cells in order to guarantee coronary access. And this is a case that we've done in Cologne, and you will see the live case, aortic insufficiency. You can see here the locators very clearly seen in the sinuses, and here the result, elimination, complete elimination of aortic regurgitation, not even a trace of leak. Very good news. And this is an interesting case that we did in Mainz, and also in Cologne, in a degenerated freestyle. And you know that the freestyle is a very complex prosthesis, not good anchoring, TAVR implants with conventional valves, challenging. Now these cases have been done very successfully, as you can see here, a degenerated freestyle, very well treated with the Jenner valve. This is the United States trial for aortic regurgitation, and look at the results here, comparing it with the CEDARS results on the right side, looking at the all-cause mortality in the first patient. I can tell you now the trial is almost finished. Mortality hasn't changed. In fact, it has gone down a little bit more. And then here you see the device success extremely high as compared to others. This is the European result. In fact, this is a German result, the first patient, commercial patient, because in Europe the valve is approved for aortic stenosis and aortic regurgitation. Look, technical success very high, device success very high, performance as indicated very high, and the pacemaker rate low, 0%. It is now with more than 90 patients, 1% pacemaker rate. So very interesting also, obviously in aortic regurgitation, no or trace of PVL, and then the gradient is very, very low. Very interesting. But now moving on to something new that we're looking into the future, the alternative materials that are being tested. And eventually it is all about the leaflets and material science innovation that will make a difference to conventional present valves on the market. And the two or three that I would like to bring a little bit closer to you: Edwards X4 Resilient Tissue Valve, the Anteris Duva Transcatheter Valve, and the Foldex Trier Heart Valve. A real glimpse into the future. Oops. Am I done? It looks like it, huh? Let me see. Another fun part is yet to start. Okay, so here's the SAPIEN XT transcatheter heart valve, a new design. And you can see here it's a novel frame and leaflet design. And this leaflet design can be expanded at 0.5 centimeters increments by using the different filling of the balloon. Very interesting. And then it does have a resilient tissue. It offers enhanced anti-calcification technology that enables dry storage. A very new valve, which is a trial that's ongoing in the United States. And here you can see the difference. SAPIEN 3, that's what we all know, the 4 sizes, and you can undersize and oversize, but here you only need 3. And the SAPIEN X4 has 3 valve sizes, 16 unique deployment diameters with 0.5 millimeter increments. So you only need 3, and you can adapt it while the valve is functioning quite well. The Foldex Trier Heart Valve is really a step beyond that. It is a valve with polymer leaflets, both surgical aortic valve and surgical mitral valve, as you can see here, and now also a transcatheter aortic valve with polymer leaflets, totally robotic manufacturing. There's no hand involved. It's all done by robots. This valve is interesting. The first implants have been done in China and in India. New polymer technology that is engineered to potentially last a patient's lifetime. Obviously, a promise, but that's what we really want. Eliminates use of animal-sourced tissue, neither pigs nor bovine. Surgical valve results more than 1 year. It's been published and successful. The TAVR is designed for ease of implant. Chronic ovine studies demonstrated very good deliverability and good hemodynamics. Another interesting valve is this one, the Anteris Duva Transcatheter Valve. It is a tissue valve with acellular detoxified leaflets and also trying to avoid tissue reaction, and it has a single piece 3D shape. It's balloon expandable, and you can see here it is by this process, it removes DNA and phospholipids and creates an acellular tissue to reduce the immune response to the leaflets. This novel 3D single piece design has its goal to restore near normal hemodynamic function, better coaptation, and less leaflet stress. So something very interesting. The first in humans have been done successfully with very good results. And finally, because I was asked to look at new technologies, the AV remodeling therapies, the one that I would like to bring up to your attention is the Leaflex a aortic valve scoring device to improve aortic valve flexibility to reduce stenosis. This is potentially interesting. The first in humans have been done. The device has been redesigned and the trial has been restarted. We will start we have started in Europe, and we will start the next cases in São Paulo in Brazil. And here on the right side, you can see the lowering of the gradient simply with scoring. This might be interesting because if we look at lifetime management and therapy sequencing, this might actually play a role in case if it holds its promises. Younger patients will likely require multiple treatments or still go to surgery. With leaflets, that can be used to either defer TAVR implants in the very old ones or delay or defer in younger patients. So it's a very interesting technology. And then obviously also the basilica, a very complex but successful procedure. A specific device for slicing is named the shortcut. For reasons of time, I will continue. But it's not only for slicing the leaflets, but also to make a tricuspid valve out of a bicuspid valve. And that is an interesting process because it might actually enhance symmetry of deployment of valves. So my last two slides, my dear colleagues and friends, if we look at the TAVR newcomers, caveats to consider, there is no single perfect TAVR system. Design optimization involves trade-offs and compromises, strong subjective opinions regarding features, which is more important, PVR prevention, ultra-low profile, low ppm rate, retrievability and repositionability, balloon versus self-expanding, etc., etc. Significant operator experience necessary to really formulate thoughtful impressions. It is very difficult to imagine to be an expert with more than 3 TAVR systems. Future TAVR systems should be expected to treat all patients with aortic stenosis. So I call it what's hot. Meaningful new versions of SAPIEN and Evolut. The industry leaders continue to iterate and innovate. Rapid emergence of other TAVR systems approved in Europe and coming to the United States, Actuate Neo2 and Navitor. New TAVR systems from China are entering the clinical marketplace, Venus A+ and J-Valve. TAVR newcomers are developing novel device designs, dry leaflet technology, PVL prevention, ultra-low profiles. Tissue engineering concepts are quickly evolving and may spark a future round of improved valve leaflet designs. And finally, new techniques for lifetime management and AV remodeling are increasingly being used. With that, I would like to thank you. We are all one world, one mission of making life better, safer and healthier. Thank you and be safe.
Thank you very much. Because of time, I'm just going to introduce Dr. Park to talk about the last 10 years TAVR path and achievement of the Asan Medical Center.
Okay. All right, so we have limited time, so I got a 5-minute talk. So it's just the previous speakers. All right, know that Alan Creviers do the first cases, and this year we are now celebrating 20th anniversary. And I would skip from the concept to practice. Actually, it took us 34 years. And the current status and current device, it's just Evolut R and SAPIEN 3. Many TAVR trials, including the low-risk patient, 2019. Look at the SSTS score is 1.9. It's very lower, and mean age is 73, 74. Meta-analysis for low-risk patients is clearly TAVR better, had a low incidence of disabling stroke, bleeding complications, acute kidney injuries, frequency of atrial fibrillation. However, higher incidence of moderate severe PVL and pacemaker implantation rate. 1-year outcomes as compared to with a surgery, lower aortic valve gradient and larger effective orifice area. So 2019 US FDA approval the low-risk patient TAVR and standard performance at 30 days and all-cause mortality less than 3%, major stroke less than 2%, vascular complication less than 5%, a permanent pacemaker less than 10%. And recent, we just started the Sapien 3 Ultra, so we need more data. However, all-cause mortality 0.9%, all-cause stroke 1.2%, new permanent pacemaker 6% is compared with the standard performance is getting better, is very enough in terms of a clinical outcome concern. And so we will change a lot in terms of a guideline, 2020 ACCH guideline. They use the age as a cutoff values more than 65 years anyway. TAVR is class 1 less than 65, SAVR still class 1. 2021 ESC guideline, they also mention about the 75 years age concern more than that TAVR class 1, and the less than that, and TAVR versus SAVR. Unsuitable for TAVR, so we think about the SAVR. So conceptual guideline for our real practice concern. Whenever you choose the tissue valve for the patients, I think a TAVR is choice, and the SAVR for only unsuitable TAVR patients. So in Assam Medical Centers, we started 2010. Sapien X valve with Alan Crivier and Co valve with Dr. Edward Gruber. So we started 2010. Up to this point, we performed 1,300 cases per year. All per year is 250 cases. And so, what's difference in our hospitals? Perfect heart team collaboration, minimalist approaches, MAC procedures more than 95%, and also we have our own CT algorithm for device selection, so pre-TAVR, meticulous CT measurement. All right. So minimalist approaching, no general anesthesia, no TE, 30-minute procedures, 1-day stay CCU, no complication, discharge on 3 days, and overall 95% cases we do MAC procedures, mainly balloon expandable stent used. There's a more analysis of data. 80 years mean age, STS score is 4, relatively low risk patient group is in our hospital. Peripheral disease 5.1%, and procedural outcomes, procedural success rate 97%, coronary obstruction 0.2%, pacemaker 6.9%, PVL 4.3%, relatively good. Compared with the different stent device type, Sapien, the permanent pacemaker rate 3.4%, Evolut R 6.7%, overall 30 days outcomes, all deaths 1.7%, disabling stroke is 1%, very low rate, bleeding complications, life-threatening one is 4.2%. Recent experienced hand, as we have experienced 260 patients, the disabling stroke is 0.3%, no actually life-threatening breathing complication. 1 year's outcome, cardiac death 2%, and disabling stroke is 1.3%, and we compare, standard performance. Last year's mortality, major disabling stroke 0.3%, very low, permanent pacemaker rate 3%. And so I would say minimalist MAC procedures improve the clinical outcome as compared with general anesthesias. In the first experience, as we cannot compare side by side. However, in terms of MAC procedures had a better procedural outcome here, and we mainly use the balloon expandable stent. Procedural success rate is a radar. MAC procedures 99% success rate. Coronary obstruction is 0.3%, permanent pacemaker rate 4.9%, very low, vascular complications 3.6%. 30 days outcome, very low, mortality concern, And we're going to compare with the standard performance as MAC procedure to be clearly, acceptable. So low mortality, low major disabling stroke, vascular complication 3.6%, pulmonary pacemaker at 4.9%, PVL 3.6%. All right, so we're going to compare with the SAPIEN 3 and Evolidal. As also, we cannot compare side by side. The reason why is we're going to start it with a, self-expandables. However, we use the mainly, balloon expandable device, right? Not too much difference, and procedural outcome to be good. However, procedural success rate, pulmonary pacemaker rate, vascular complication is a bit lower, and balloon expandable, right? So we're going to compare SAPIEN, and it's quite comparable. However, still, the pulmonary pacemaker rate will be higher, so going to be the cold valve. So durability issue just mentioned by Eberhard Gruber, just published data, pattern 1, 5 years, very much comparable with the TAVR versus SAVR. Those on at 8 years exactly equipoise between the TAVR versus SAVR up to this point. So 5 to 8 years after TAVRs, up to this point, TAVR is still comparable with the surgery. We have remaining issues. Bicuspid valve, we discussed a lot of bioprosthetic valve failures, asymptomatic AS, low flow, low gradient AS, high risk ARs, routine use of cerebral protection device, etc. And so, current 2022 practical, guidelines in our hospital. Whenever you choose a tissue valve at any age, at any cases, TAVR has become the standard treatment in patients with a symptomatic severe aortic stenosis more than 65 years. SAVR would be considered only for patients for not suitable TAVR. Thank you for your attention.
So, SJ, I think we're coming to an end of this session.
All right.
Thank you very much. And you
all right,
continue.
it's great session. Thank you again. So we're gonna move next live case and lecture sessions. So TAVR for bicuspid valve. I'd like Alan, right. Invite Alan and Myung-Ki Hong is here. All right, come on in.
Great. So we're just going to move straight into the TAVR for bicuspid valve session. Myself and Myung-Ki Hong will be the moderators, and Dr. Che, Dr. Liu, Dr. Du Park, and Dr. Wu will be on the as discussants. See you in real person. I've seen you on Zoom a few times.